All right. Okay. Hello, everybody. We are here again at Dante Pazanesi. We are in the lab one to present a challenging case to you. Uh, it's going to be uh, done, performed by Rodolfo Staico, who is going to be the first operator. Rodolfo is here. He's the chief of
Hi.
coronary intervention. I also have Louis, Jose Henrique, and also Patrick beside me. And we have been working here for 30 minutes or so. And we are going to discuss the case. We have a very experienced team of nurse, anesthesiology, and technicians. And we are so happy to be again at MedStream 306. And thank you, Samir Mehta, and all the organizers for this. Louis, may you have the slides, please?
Yes,
We are
thank
going
you.
to present the case, please.
It's a coronary intervention for a very calcified lesion here. It's a 61-year-old female. She has a non-stem past week, Fausto. She's
Mhm.
asymptomatic since then. She has a comorbidity. She has a hypertension and she's a current smoker. Uh,
So she came to our emergency room.
yeah,
Okay, good.
yeah, yes, with an stem here.
Sh-
She
sh-
has classical angina here.
Yes, I saw this,
Symptoms.
Kath. It was last Friday.
Yes,
Yes.
Saturday.
Saturday.
Saturday,
Saturday,
yes,
yes.
Saturday.
Saturday. Saturday morning was performed
By me.
by you. Okay, good.
She
Okay,
was.
we are gonna get some back return here. It's possible to. Okay, good. Thank you. Can you? Okay, eliminate this, please. The. Okay. Thanks.
The reverb
The
here.
river.
Thank you. Yeah, thank
Yeah.
you. Yeah, so she's taking aspirin, clopidogrel, atorvastatin, and Lapril, and she has laboratory tests. There's normal renal function. She
Okay.
has normal. She did echo. She
Mm-hmm.
has a preserved LV function with a little hypokinesia inferior wall and infralateral wall.
Okay.
Here EKG, rest EKG, she has some, how can I say, some, perhaps a little bit slow progression on the
Uh-huh.
anterior leads,
Uh-huh.
and she has a wave in the inferior wall. So
Okay.
it's somehow she has some disturbance, a little bit of a atrial, how can I say, hyper. She has
But she was asymptomatic at this moment
yes, I
when we
see.
did the cath.
Yeah,
Okay.
she did
No
have
chest pain.
no chest pain. She has a little
Okay.
bit on the past month. So she has angina on
But she
rest
came to
angina.
our emergency room.
Yes.
Okay.
So we did an angel and the cath lab. She's on right on the right side. She has on the left. She has we can already see some disease on the LAD in
So
the
the
pro.
yeah, small circ. The
Yes.
most important thing that I see here, beside the lesion, beyond the lesion, it's the small circ.
Yes.
I can realize the right is going to be a huge right.
Yes.
Okay.
And we did a little bit. I don't know.
How severe are the lesions in the LAD?
The lady, I think she's moderate to severe lesions on the mid portion and a little bit on the distal portion.
It's
After
about
the,
40, 50,
it's
60,
60%.
60%.
Yes,
60.
6% on the proximal,
Okay.
and a little bit of 40 to 50% after the second diagonal here, or
But
this.
probably this is not the culprit lesion.
No,
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 the culprit
probably
lesion.
not there. So,
Okay.
so we did mid calcification here.
Mm-hmm.
In the left, we already see some of perhaps the proximal circumflex, but it's small circumflex, as you already said.
Okay.
In the spider view, we have seen the proximal circ and
Uh-huh.
the LAD severe lesions. Okay, so from the right side, on the right. Okay, so we see a severe lesion,
And
really
also
calcified.
a huge calcification
Yes,
in the proximal part of the right.
yeah, proximal and a little bit
Distal
less
too.
in the distal tube. And the PD and the PD is not so significant, but it has a 9% stenosis in the proximal.
Uh-huh.
We also see the huge calcification,
You mean the PDA?
PDA, and
Uh-huh.
the PL. We have also a significant lesion in the inferior segment of the subramals, inferior subramals.
So you have four lesions, main lesions in the right.
Yes,
Four main lesions in the right.
yes,
So
correct.
this lady is only 61 years old.
Yes.
Do you have any other slide or no?
No, and we have the preservative function
Uh-huh.
with a hypokinesias in the ferrule.
Okay, good. So we have here a lady, a young lady. She's
Yes.
only 61 years old.
Yes,
A huge calcification of her coronary arteries. She's a smoker for several years.
yes. Current
So
smoker.
current smoke. Okay.
Yes.
Uh,
So I performed the angel. I thought it was how can I say a pre-calcified lesion, and a very complex case here.
okay, yes.
So we
Could
have,
we send this patient to surgery?
of course, we could.
Okay.
We could. We
How about
have,
the distal bed of their
perhaps a little
left-
bit, yes.
left system?
Yes, the left system perhaps would be how can I say to be considered on a heart team, and from an expert surgeon to, if it's allowed to do internal memory on the left system.
Okay,
from
but how about the
distal-
right? You have lesions in the PDA and also the other branch. How can you see?
Yes.
How can you do this?
Yes, that's complex because we will have four lesions on the right side, so there will be a little bit complex to do a how can I say a saphenous graft
Okay.
over there.
I would say because of the distal lesions, I think it's make a surgery to do an open heart surgery really hard.
Yeah.
For the surgeons and where to put this to do the bypass. I think
Not
I think
very
it's
appropriate to surgery.
Yes, I totally agree. And the patient is ACS, and she's on clopidogrel and
Yes.
aspirin,
Clopidogrel and aspirin since she
and
was
it's asymptomatic.
asymptomatic since the past week.
Okay, what is the strategy for today?
The strategy is to go for the Cropper lesion. That's the RCA.
So there is some tortuosity.
A lot of tortuosity.
Okay.
I will say. Tortuosity.
Let
and the
me ask you,
calcification.
Rodolfo, now. What did you choose femoral access? So why did you choose femoral access?
To use in the complex case a set French catheter.
7 French.
Yeah.
So this is the first.
Radio is not enough.
That's
to,
the first lesson from Dante. Sometimes when you have a very complex case with tortuosity and also calcification, and the small lady, smoker, the radial artery usually is not so good.
Not good.
So we choose femoral access.
Femoral
So
approach.
would you choose a 6 or a 7 French for this case, Rodolfo?
7 French.
7 French.
7.
Because you want to have a strong backup support. Is this the answer?
Yeah.
For 7 French guide. So 7 French guide, femoral artery, and what kind of guiding catheter would you choose for this case? Would you use a JEL or an
A
Amplatz?
good support. And
Good support. Amplatz.
A,
Can you show the angel, please, with the first
The first
acquisition
angel,
that you
yes.
had, please?
Okay. So the angel here falls to
Yes. Great.
Yes. Okay. So
Okay,
we
so
already
you
see, yes.
it's AL1 or AL2?
AL1.
AL1. So we got a good backup support with a 7 French guide, with an Amplatz, and to do this
the
very
takeoff of the RCA is not, it's superior.
superior.
Another,
Good point.
Yeah.
The ocho is superior.
Yeah.
So
the takeoff.
this is a
Challenging.
challenging case. So we have the superior osteon. The backup usually is not so good in this situation. Second, we have 4 lesions at least. 4 lesions. Actually, we have 5 because we have a lesion in that marginal branch. I
Yes.
saw that picture that you showed nicely. So, and we have calcified, strong calcification of this artery.
Tortuosity.
And tortuosity too. Okay, good. So we have all the factors to get an successful. So this is a challenging case to do this in this lab. Rodolfo, what kind of guide wire did you choose?
We try, the first one is a workhorse, it's a BMW.
BMW?
So we
But,
just filmed the repressing through the lesion.
Okay.
So although it's a tight and really lesion on the proximal to the mid-third portion, we did good guidance from the guide wire. So
Okay,
we
with
didn't
the
have
guide
any
wires.
trouble. Yes, we didn't have any
Maybe
trouble.
So that's what we have done so far. So you try to get the BMW there.
Yeah.
Yes.
It was easily.
Easily.
Maybe it's necessary to to put
Mhm.
a polymeric wire,
So-
but the BMW works well.
So would you do a pre-dilatation at this point after you get the wire down, distal? Is that correct, Louis?
Yes, perhaps, but what we try to choose is try to make some pass through a guide wire through the PD also because it's a severe lesion.
Okay. Did you
Yes, we did.
did you get successful?
Yes, we did get successful.
Okay.
But as we can see in the angel, we are trying to pass a non-compliant balloon 2.5,
Okay.
225.
but we didn't get
225.
any success.
2.5.
225. 225.
225. 225.
225.
Okay. 225 balloon, non-compliant balloon.
Yes.
Did you get successful? No.
No.
Where did balloon stop?
Stop a little bit on the
Do you have the
curve.
picture there?
Yes,
Can you show us?
You're
Picture
seeing here. You can see the.
Let me see.
Here.
Let get close. Oh, okay.
You see?
So you come on and you stop at the lesion. Exactly at the lesion.
Yes, the lesion.
So it had a severe lesion.
Yeah.
Can you go back and just show the lesion again, please?
Okay, first. Okay.
Yeah.
Here.
Okay.
It's a really
Great.
tight, calcified
So it's
lesion.
90% lesion,
Yes.
calcified, tortuosity,
Yes, it was fun.
and some difficulties.
Yes.
So, and then what you do now?
Well, we tried
A smaller balloon?
yeah, we could try a small balloon, but we try we try Godzilla, so a supporting catheter.
Okay.
So we just stopped in the proximal lesion,
Diga.
and we
So-
tried to.
So you did the mother and child again.
mother and child.
But even with a severe lesion, do you think it
Esse não dá
would
também.
be okay?
Tem que abrir.
Yeah, perhaps not should press through the lesion, but just to get
I know.
up on the
But why the balloon did not cross the lesion? Because of the severity, or because of the calcification, or because of the
Precisa abrir
tortuosity? You
both,
have three options.
perhaps the
Precisa
three.
abrir.
The three. Okay.
Voltado.
Three of them. So we have tortuosity, we have calcification, and we have
Tem que abrir.
severe lesions. And this small balloon with a 225 could not get across.
Yes.
If I could choose one, I would choose the severe lesion
Okay.
because it's so severe
It's
and the
tight.
calcification tight.
It's really tight.
There is no room. There's no
Testar.
room to balloon get through.
Yeah.
That's important to mention. So, may you have, if you did not get successful with the mother and child,
Well, so we have.
What's next?
We have to pass through the lesion. So we thought about using a atherectomy.
Atherectomy.
Rotational
so you need
atherectomy.
an additional preparation.
Yes.
The balloon could not make the job.
Yeah. The
Okay.
balloon.
So you need to choose for the rotablator.
Yeah. So.
So if you have other option, you have laser, and you also have shockwave.
Yes. Have shockwave.
There is no possibility to use
No,
it.
because if the balloon doesn't pass, of course the shockwave will not pass through the.
So this
lesion.
is the main indication for atherectomy.
Rotational atherectomy.
Rotational atherectomy.
Perfect.
So you have the rotablator.
Yeah.
Ready?
Just to make an explanation, because we do
You need to change the wire.
Yes, because the rota wire
Okay.
is a little bit thinner.
Okay.
So
What did you do then?
we use a Mamba Flex. It's a microcatheter.
Microcatheter.
Yes, so you can see
Oh,
here.
what's the name of the microcatheter you use?
Mamba Flex.
Number from Boston Scientific.
Yes, Mamba
Mamba
Flex
Flex.
from
Did it
Boston
go
Sci-
through easily?
so easily, so smooth. You
Can
see,
you show us?
Yes, in the screen here you can see
Okay. May I see?
passing through.
Oh, great.
See how smoothly
So
he
you-
passed through the lesion.
Okay, great.
It's a polymeric microcatheter here.
Do you think
so
as if
far.
you had a Rodolfo, if you have 1.0 balloon, could get across? Because you could get with the Mamba.
Yeah.
Perhaps.
I think so.
Okay.
But the proximal calcification is so hard.
Okay.
And I
You need
will have
to
difficult
work a little
to-
bit on there. Okay.
Yes, perhaps so you can upgrade the
So-
balloons. né?
So you change the 14 wire
Yes.
for the 9 wire.
yes.
Yes.
And so here is you are retrieving the BMW in the screen. Here.
Uh-huh.
And
Can
we're-
you see that?
Yeah, here you are retrieving the BMW.
A BMW. That's a very good tip
Step
and
by
trick.
step,
So
yeah.
you don't want to just take everything out and bring the guide wire again, the rotablator wire, the rota wire. The best thing is to
Vamos tirar
put
Yeah.
a catheter, a microcatheter distal. It was chosen by Mamba, and you
So you
took the BMW wire out and you brought the rota wire.
yes, so we can exchange in a way that's secure.
Okay.
And how can I say the?
Can you show? Okay, now we are
Yes.
seeing your hands.
Yes.
You are bringing back the mamba catheter,
yes, and leaving the
rotowire distal.
rotowire distally.
Okay.
Yes.
Being so concentrate now,
Yes. Yes.
and you have the rotowire. I'll
Rotowire.
talk, and you'll be concentrating helping Rodolfo. Okay.
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 Thank you,
Great.
Fausto.
Nice.
Thank you.
Okay.
Okay.
You just
It's
got
out.
off
So
there.
now you're gonna clean the wire. It's
Yes.
very important for rotowire to clean the wire. We are cleaning the wire. Bring the mamba out. You're gonna use this microcatheter later,
Yes, perhaps.
perhaps.
So
So
you can
need to
we
take care
can-
of this.
we
I'm
can
giving
trade
to
off
Patrick.
Okay.
the rotowire for the BMW.
BMW. Okay.
Okay. So we are now
Later.
preparing the.
So it's better to clean the
Ligou,
catheter
soro.
Yes.
to
yes.
avoid any
Tá ligado, soro?
thrombus or everything.
Tá ligado, Soda?
Always when you take a catheter out, you need to clean the catheter.
Ok.
There's a rule. It's important. Now,
So
Patrick
now
is cleaning the catheter.
Yes.
You have the rotowire now.
Yes, we are opening a little bit so you can.
Rodolfo is in
the
his hand
titration.
with the
Yes.
rotablator device. So, this is a challenging case. So, when you have a right coronary artery with tortuosity, calcification, and severe lesion in superior ostium,
Okay.
there are 4 factors that can make your procedure very hard.
Just a little
To
bit.
do.
Yes. Okay.
Okay.
Okay?
Okay.
Are you going to make a test now?
But the,
We started using rotablator at Dante in 1992. 1992. 31 years ago. We learned this with Maurice Bookbinder at the University of San Diego, South California. And he was the first to use this. The company for rotablator at that time, it was called Heart Technology. And Maurice was doing several cases, and I had the opportunity to go there and to watch the case that he was just starting doing. And Mark Heisman was his fellow at that time in 1992,
Long time ago.
long time ago, and we brought to use it here at Dante.
160.
we are-
160.
Just testing
Mas-
the
não.
blur,
Devagar, Patrícia.
the velocity from the
100
rotation.
in?
Pra cima. 160.
160,
160,000.
160. Okay.
Mais.
If you want to show the monitor here for a rotablator, good, good. Okay,
Okay,
160.
Okay.
Check dyna. Right, okay. Perfect. Go. Let's go.
Wagner, fica para trás que você está aparecendo na câmera aí.
Vamos lá.
Ó.
Subindo.
Okay. Rodolfo now is bringing the burr.
Tem que apertar o freio, senão não sobe. Aperta aqui.
The device was tested. Everything is fine. The patient is fine with blood pressure and
Okay,
also
okay,
heart rate.
okay.
Maybe we can, after this, we can just bring the hemodynamics when we got the heart. With the hemodynamics and in the video. Now he's bringing. Louis is just holding the wire with pushing the button here, as you can see here in his hand, right here. And now Rodolfo is bringing the burr. Hopefully we can get cross of that tortuosity. He's gonna get the guiding catheter inside of the artery right
Patrícia,
now.
tira a mão. Pode tirar. Sai. Pode ir. Esquece.
Now it's time to pay attention. I'll try to do the relation. I'm going to relate the case now. Rodolfo is bringing. So this is
Okay.
Sterzer. Simon Sterzer was used to do this to across the burr. So we just with a small acceleration of the system, small and short. Now we have the burr pretty close to the curve, and he's starting acting this, as you can see here. It crosses easily. He's going a little bit distal to the second lesion. Trying to work it. And you have the hemodynamics on the screen. Can you have the blood pressure on there? So the heart rate is okay. You have the blood pressure there?
Yes, because of the, I think yes. Okay.
Okay, it's okay. Blood pressure is fine.
Tropina,
We are giving some fluids to this patient. It's a little bit 90 over 50.
Soro.
So let's get some fluids, please.
Yeah.
Abre o soro, por favor.
Right.
Okay.
Okay.
The blood flow is okay, as you can see here. Now, usually how many passages you do this, Rodolfo? How many you get through the lesion? One in one?
Only one after easy.
Okay.
Yes. To polish the
Okay.
final polish.
So you're gonna do any more?
Yeah.
Okay, one more. Okay. Now we are running about 140,000 with a nice demonstration of how to do an ablation of this artery, and quite easily. Again, blood pressure is fine. Now is about 100, and heart rate is okay. So now I'm gonna test just to see the flow. Did you inject some nitro after?
No, we didn't thought so because
Of the blood pressure.
Yes, the blood
Okay,
pressure.
let's see the flow. Distal flow.
Okay.
It's fine. It's great. Now you are gonna bring it back the bore.
Okay.
What is the size of this bore? Is 175? 1.5.
1.5.
1.5. So when do you choose to up with a larger bore? In this situation, Rodolfo? Louis?
Yeah, perhaps also if you
Right,
can
start.
across, if you think you can open the vessel with a non-compliant balloon after,
Okay.
we would not choose a
Let me
upgrade.
show an important point. We brought the what's the name?
Yes, it's a butterfly. I don't know.
Control wire.
Yes, yes.
This is the control wire in my hands right here. If you can have the hands, and Rodolfo is going to take out this. Louis, stay there. Stay there. There, over there.
Thank you.
And we are going to just keep the wire here. And Louis is going to push in the button. So in bringing it back. Now we are 60,000 rotation, as you can see here. Louis is bringing it back with the hands, with the rotation. Can you see here the rotation device? So, and Rodolfo is just paying attention. If you bring the camera here in the Rodolfo's hand, please.
Okay.
Yes, good. And Rodolfo, do you think you need to upsize the bore to 175?
No, I will try with put
A balloon?
first. It's a support wire, guide wire.
Okay, but how about a larger
now-
bore? No,
No.
no
I
larger
will
bore.
try with
Do you think 1.5 is enough?
Yeah.
That's another important point in this technique. So we are gonna keep just one bore, 1.5, and now he's gonna exchange the wire again, the Mamba catheter, the micro catheter. If you look at the Louis' hand, Louis is preparing the Mamba
Pega BHW.
and change the wire, the rotor wire. We cannot forget the rotor wire is 0.009. We are going to change now the guide wire to a 0.014.
Yeah, extra support one.
Yes, extra support one. Good.
BHW.
So, have you tried to go with a balloon through this wire? It's really hard.
Here, Rodolfo.
In
No.
this case,
No, no possibility.
It didn't work.
So another important point. Now we can take the hemodynamics out and just focus on the hand, please. The camera only in the hands here, and also in the room, if it's possible. Thank you. Thank you.
Now you can see the angel. We are trying to exchange the guide wire.
Okay. So yes, may you have the angel? Yeah, great. Thank you. Now we are looking at the end. Louis is holding the wire. Rodolfo is advanced the member the microcatheter by Boston Scientific. That's a very good microcatheter.
You see how smoothly it
Yeah,
goes
yes.
through?
It's very easily. But I think at the first time it was so easily too.
Yeah.
Now the microcatheter is distal. Take the rotor wire out
BHW.
and bring an extra support guide wire. Then
BHW.
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 So for starting, you start with a BMW, yeah?
Yeah.
Now you have a BHW.
BHW.
Okay. So you start with a BMW, now you're going with a Mercedes.
Yes, a
Okay,
Mercedes.
good.
An Audi.
They cannot hear. Okay. Now we have the distal part there. If you look at the Rodolfo hands, he's advanced the wire, the guide wire. It's very important, so smooth. We don't want to get any perforation in the distal vessel. And now
Tirar aqui.
Louis is going to hold the wire
Aqui, ele é
and
pequeno.
bringing back the mamba,
Right.
the microcatheter out, as you can appreciate in the screen. Very nicely exchanging wire.
Balão, Rodolfo.
And also a nice demonstration. Now, just for them who did not watch the beginning, this is a tortuosity vessel, very tortuosity vessel, calcified, severe lesion in the superior takeoff of the right.
Tentar o balão.
The balloon
Yes,
did not cross the lesion,
2,25.
and we decided to use a rotablator that was done with a 1.5 burr that was performed very easily. And after the exchange wire, the rotor wire, we had now a 14 BHW wire and bringing back the 2.25 balloon that was unsuccessful at the beginning. Is that right?
Yes, we're now trying to 2.5 here, non-compliant, because we have already used that one before.
Okay, now it's choose a
2.5.
0.5. Let's see if you can get across easily.
Easily.
So this is the rule of rotablator, and just to open the room and to provoke a decalcification of the artery.
There is some nodule of calcium.
Yes,
no?
some nodule of calcium. Good point. Now we have the 2.5 balloon
distally from
distally,
the RCA.
RCA to open the two vessels, and we still have two lesions in the distal.
Yes,
We cannot forget PDA
but we cannot try
and the posterior branch,
Yeah,
the
but
two posterior branches.
Yeah, but we cannot treat the distal if we
Yes.
cannot across the proximal and the.
Great demonstration. Now we have the 2.5 balloon there. Now it's very important to see the expansion, because if we did not get a perfect expansion, even with high pressure, maybe we need to change the strategy.
Yes.
Let's see, 2.5 balloon. Let's see.
High pressure.
Great. Now it's the balloon is
25.
full,
25.
25 atmosphere.
Deflate.
Balloon is full expanded. How many seconds? Only 10 seconds?
10
Yeah.
seconds.
So you're faster than anyone that I
Right.
I have worked too. Now, look at the heart rate is okay. Blood pressure is also okay. Again, as you can see, the 2.5 balloon with a 25 atmosphere.
Okay.
High pressure balloon.
28.
Okay.
Deflate.
Do you think it's fully expanded in the proximal?
But
We don't need a 3.0 to a better preparation of the artery?
We need a bigger balloon.
A bigger
3.5,
balloon.
Yeah.
3.0. 3.0 or 3.5? You are going to do
3.5.
that, or you're going to place a
One,
stent first?
One by one relation. of
Okay,
course.
one by one.
One by
The
one.
preparation.
The preparation.
How about the stent size? Why don't you come with the stent right now? Can you explain us?
Maybe Ivos.
Ivos now?
Perhaps rivals, but the
Yeah, we
fear-
have time.
Yes, we have
Yeah,
time.
we still
also.
have 25 minutes to go. But
I think this is
Do you
a
think it's
4-0.
imp-
It's a
it-
4-0 artery.
okay, do you think it's important to do Ivos now? Just to,
To demonstrate, okay.
Okay,
Just
folks,
a- no. Maybe
It's
we're going to
important.
use
Yes.
angel, like you do routinely. Okay?
Okay. For
At the end.
you're asking, Fausto, if you can
For-
choose to
for
use
balão
the
4.0.
stent now. But the fear is
No,
that
what I'm asking you,
Yes.
let me ask you, let's put everything together. why can you come with the stent right now?
Yes.
And do the overexpansion with the stent?
Yes.
You say, and Rodolfo say later, okay?
Yeah, we have the fear
20.
from we not get
20.
fully expanded,
20.
so we can be trapped with a with a stent not fully open into the right
Okay.
artery. So that's
So, but you saw the balloon was completely open. The stent, you don't know.
yeah, we
Okay.
don't know.
But 2.5, not 4.0.
Okay. So you need to
It
see the
needed
4.0.
one
But you're going to
by
use a
one.
high pressure and the 4.0 too? Because you can get a dissection.
I'm seeing the reference image.
Mhm.
I'm looking.
Okay.
I decide of
A
the
4.0.
pressure.
So you're still preparate the
5,
lesion.
10,
You're still preparate the
14.
lesion.
Yeah.
Okay.
Yes.
So we're going to use a 4.0.
Yeah.
Great. Let's see.
It's a 4 by 20.
Pressão.
So the distal lesion is going to be prepared too with a 4.0, also to a 4.0 or not?
Pressão.
Rodolfo, can you give some fluids, please? So the blood pressure is a little bit down now, is about 55, 50, 60. So open the fluids, please. Thank you. Thank you. The blood pressure is getting better now. So we have a very good guide support. The 4.0 by 20 balloon is going to be, oops. So maybe we need to have the, still some another
Yeah.
of calcium there. Whoops. See, that's very important.
Yeah.
That's so it was quite easily with the 2.5. We went from 2.5 to 4.0. Maybe it's better to bring a 3.0 now, Rodolfo.
We have a Godzilla.
Godzilla again?
Again?
Okay, let's try the Godzilla.
Okay. Thank you.
That's a good option. We still have the Godzilla on the table.
Yep. You're using
Okay,
now.
good.
Okay.
So last time you used it from the Terumo. Today we're going to use Godzilla from Boston. From Boston.
Yes.
So now we have the Godzilla here, the mother and child, and to get across with the balloon. So the problem was not only the lesion, it was, the tortuosity and the calcification. Because the lesion is full open.
Yep.
There's some calcium that can maybe make this
Perhaps
hard across.
yes, perhaps a calcium nodule that will
Okay.
not allow us to
Okay.
pass through the device here is false.
Okay,
So-
great. Now we are bringing the Godzilla. I like the close, so you're going to come the camera closed. This is the Godzilla. Good.
Balãozinho preparado, 2,5.
Yeah. So we are going to bring the 4.0 through the Godzilla.
Okay.
Yes.
Okay, let's see the rule of Godzilla. 2 weeks ago, we used the shock wave, and we need to get across that lesion with a shock wave.
Yeah.
And you use the Godzilla. That time it was ST8.
STA.
ST8 from Terumo, yes?
Yes.
Do you prefer Terumo? No. No. The Japanese, they usually like Terumo very much.
How?
Yes.
How?
It was a nice demonstration of the Godzilla. So we had the unsuccessful balloon, the pre-dilatation. We used the rotablator.
And distal.
We did a rotational atherectomy, and we pre-dilate after 2.5. When we brought the 4.0, we could not cross with the 4.0. And now, with the Godzilla backup support, mother and child technique, and
Devagar.
we
Yes,
could
right.
use a 4.0. Now,
Right.
We are
not
on
very
four-
high pressure.
Yeah, 4 atmosphere here, Fausto.
How big is the artery distal?
How big is
It's
the...
What's the size of this artery, Rodolfo? Distal? 3.0, 3.5?
No, 4.0.
4.0. 4.0. It's a 4.0.
Teste.
So what's the pressure you use here, Louis?
4 atmosphere. 4.
4 atmospheres.
Right.
So
Yes.
we use the 4 atmosphere,
Now we're going up to 6 now.
Right.
6 atmosphere.
10.
Great.
8 to
10.
10 here.
10, it's almost
Yes,
fully
15.
open.
Yeah, yeah.
That's a good lesion preparation.
Deflate.
I like that.
Mais proximal.
Can you do anything more to prepare these lesions,
Teste.
Rodolfo?
Right.
How about shockwave at this point? Do you think that it's good? Would have a rule?
If the NC
balloon is
balloon
complete-
works, okay, it's not
Okay,
necessary.
you're not necessary. Good.
I think
It's
so.
open. Completely open. The balloon is completely open, fully open. We went to up to 10.
10 and distally up
Okay.
to
Okay.
40.
Now Rodolfo is working the mother and child technique. He's gonna be in back the guidezilla. See, the guiding cat is a little bit intubated in the right coronary artery, but the guidezilla is back, and he's keeping the balloon exactly on the lesion.
Here.
Okay.
14
Now,
atmosphere here.
14 atmospheres, the balloon is fully open. That's important. So after you have the balloon fully open, we don't think we need to use shockwave. Is that correct? That's
think
important.
so.
Yes.
That's an important teaching point. So we use the rotablator. We use two balloons now, 2.5 and 4.0. And hopefully we could get a good preparation of the lesion. And I'm sure you're gonna use guidezilla to get across with the stent or not? Can you do that and keep the guidezilla over there?
Yes.
I think it's a good option.
Test. Okay.
Unless you want to test
Sobe.
the stent.
Sobe.
Let's see if we can go with the 4.0 now.
Just doing the preparation here, Fausto.
Okay.
Can you do a test with the balloon now, just to get, if you can get across distally, Rodolfo, please? After deflate the balloon?
That's a good tip for
Yes.
intervention. So
Yeah. Let's see if the balloon. Good distal flow. And let's see.
It's like a simulation for the
He's
stent.
bringing with his left hand to get a better support with the guiding catheter and pulling the balloon, the 4.0 balloon. So, see, it's a little bit hard. Sometimes the stent didn't go through if you don't have a guidezilla there. That's my opinion. Let's see with the guidezilla. Again, he's bringing back the guidezilla to make the test, to put the guidezilla close to the lesion. See, the mother and child now, he's pretty close. Good. The guidezilla can get across everything, and you can bring the balloon back, keep the guidezilla there. How about the distal flow with the guidezilla? Do you think it's good?
It's good.
Or even with the guidezilla in place?
Because the flow
Yeah.
get proximal to the guidezilla.
Yeah. There is some holes.
Yeah.
Yeah, there's holes, but we do the preparation with the 4.0 balloon.
Okay.
So
But you need to be a little bit faster to prepare this.
Yes.
Okay.
So we're going to choose the stent now here. We're going
Don't
to
you think it's better to bring the guidezilla a little bit
Stent
proximal?
4. Stent 4. 35.
4 by
4.35.
35, please. 4.0 by 35. So you are going to bring in back the guidezilla, the balloon. Is there any problem with? I think it's a little bit distant. So, the flow is good. It's about 2.
Anestesia. A pressão tem que ficar em 10. Sobe. Em 5, sobe a pressão. Adrenalina. Efedrina.
Okay.
Vai, stent.
We need to be a little bit faster because it's a huge right, and the flow is a little bit
Pressão é 10.
lower than we begin.
Vai rápido.
The distal flow, because you have the guidezilla there. Rodolfo is just to get better from the guidezilla. Work a little bit fast now with the hands and bring a 4.0 by 35 coronary stent in the distal lesion and to give some flow to this coronary artery. So the distal flow is a little bit down. Now the stent is there. He's going to bring him back the guidezilla. Can you see that?
Yeah.
Bringing back the guidezilla. The stent is in place.
Teste.
We're going to test to have the better position that we have. Yes, okay.
Ok.
Okay, perfect.
Okay,
Sobe.
inflate. We are going to get all the lesion there. So the stent is a 4.0 by 35. We are 6 atmosphere. We need to be careful to the distal.
Ok,
No, not with high pressure
Deflate.
at this point.
Deflate.
What kind of stent we are using here?
Or Ciro.
4.0 by 30. Okay. It is IC this?
No, or Ciro.
Outro.
Oh, or Ciro. Or Ciro by Biotronic. 4.0 by 35.
We can open another.
Another
Or
stent.
Ciro,
Another stent.
or Ciro stent.
Yes.
What size do you want? A 4.0 by
4.0 actually would be the same length.
35 too?
Here.
O mais
Ok.
longo que tiver.
Yeah. The
The longest that we have here.
Não, 35.
Qual o mais longo que tem aí? 38, 40? 40 by 40, Rodolfo?
Peraí. For
We have 40 by 40, 40 by 38, and 40 by 35. Which one do you want to use?
40.
40. 40 by 40.
40. Isso.
So the distal flow is better now? Did you test?
Yeah.
Okay. The blood pressure is better. It's about, now let's see. It's about 90, 80. Let's see. It's, at this time, do you think we should keep the Godzilla over there? Just
we
First
did get-
cross with the stent.
Okay, just to cross. Bring it up. So we need to work a little bit faster at this time. We still have time because we still have 15 minutes to this very tough right to be treated. We still have the 2 lesions in the posterior branch that we are going to ask them the strategy, what to do there. Now, Rodolfo, if you look at the Rodolfo hands, he's bringing the 40 by 40, as you can see here, through the Godzilla, the mother and child technique again. That's very helpful. See, you can see the stents over there. It's important to mention, even with
Now,
the mother
I
and
will
child, the
pull back
Godzilla,
the
in the
Godzilla.
pre-dilatation, now he's pulling back the mother and child. I mean, the Godzilla.
And the catheter, the
The guiding catheter also need to be in the ostium. So you're going to try to take that lesion in the proximal part. He's so carefully bringing back the guiding catheter with his left hand. As you can see, if you look at if you can show the left hand, Rodolfo left hand, please, it's important. Can you open a little bit the camera? Open a little bit the camera, please. Okay, good. And you can see the left hand, both hands. So this he's
Dash.
working with both hands,
okay, sorry.
pulling back the stent with the right and control the guiding catheter with the left. And now Louis is inflate the balloon, the stent, with a 40 by 40 or zero that's made by Biotronic. It's sirolimus, yes?
Yeah.
Sirolimus. Sirolimus drug-eluting stent with a biocompatible polymer. Is that correct?
Biocompatible. It has really thin struts, Fausto.
Okay, very thin. It's about 60.
Yes.
Okay, 60 micro.
Dash.
Okay,
Looks
that's
really
a
good.
very good flow. Now with both stents, we still need to work on the stents, man, because we just deployed at 10 atmosphere, the maximum.
Yeah.
Could you go with the same balloon and because you have an overlap and go down and try to do post-dilatation with the same balloon, Rodolfo, or not?
I prefer
Let's test.
LC
Let's see.
balloon.
It's
But,
possible.
Let's see.
Let's see. No, doesn't go through. Now, I think we need to use the Godzilla also to be close to, again, to help you this. This is a very nice demonstration and how helpful it should take this technique in mother and child. And doing everything with this. The only device that go through without mother and child was the rotablator and the 2.5 balloon.
Yeah.
Is that correct?
Yes.
The preparation with a 4.0 balloon did not go through. And also the stent did not go through without using mother and child technique with Godzilla at this point. Now, Louis, if you look at the hands, Louis' hands, now the blood pressure is fine. Good. You give some fluids. The blood pressure is fine.
I'm going to
Thank you.
non-complain balloon and do post-dilatation here, Fausto.
So now we are take a 4.0 by 20. No,
Yeah, the same.
or the same balloon you did the pre-dilatation.
Yes.
Okay, good. So,
We will try.
okay. Let's see. Without doing IVOS, we did not do IVOS. You can do that only by angel, and we are going to try to check the results with IVOS at the end and to see what Rodolfo is going to do with the posterior branch, the 2 posterior branch, the distal lesions. Let's see.
Right? One trick. You inflate
Okay.
the balloon.
Okay.
Inside the catheter.
Inside the catheter,
10
just-
atmospheres. Okay.
Just to get a good deflation, because the balloon was used before
Yes.
to do the pre-dilation. So if you inflate the balloon inside the guiding catheter, deflate pretty fast and bring the balloon. Didn't go through?
No, the Godzilla.
What happened with the Godzilla?
But the balloon is huge.
You need to take
It's a
another
huge-
another
yes, we're
balloon.
going to use a new one here.
A new one. Okay.
A4024.
So this is a very expensive procedure.
Yes.
But we're not going to save money with only one balloon.
420.
So we use the rotablator, mother and child, guiding catheters, several wires, balloons,
Micro cutters.
microcatheters.
15 então.
So
It's
it's
3
an
to 4
expensive.
guide wires here, Fausto.
Yes, but if you want to do a procedure like this, you need to be very well equipped. Your cath lab needs to have everything to do this, because this is our routine to do difficult procedures like this. It's important to follow all the technique. I used to say to our fellows here, it's like when you do to pilot an airplane.
Yeah.
Is that correct?
Yes, correct, Fausto.
Okay, so we have to follow the rules.
Yes.
If you do not follow the rules, you may be in trouble. If you cannot have in your mind, write and all the rules and just tape it in front of you to remember everything. Now we have also, if you look at the hands, Rodolfo hands here, he's advanced the 4.0 balloon, keeping the wire, 4.0 by 20. And now, let's see the mother and child there, if you can go with a new balloon. See, now he's getting that. Yes, it was quite easily. Great demonstration. The mother and child was proximal distant and give some support, and the balloon to post-dilate the lesion. Now we need to precise the position, to be so precise. It's important because you have calcium there, and sometimes you can make a confusion between calcium and stent struts. Yeah. Can you do the stent pulse or something like this?
Yes.
It's okay.
I know you're okay, but let's see a demonstration there because you have calcium there, and when you have calcium,
Boost.
Yes, you're trying using here. Just up here, Rodolfo.
just to see, we still have time, Rodolfo.
Yes.
We are okay.
Position.
I'll leave you to. We try to do
now.
IVUS, and after I'll let you to work on that posterior branches.
A little bit out. Outside the stand here, Fausto.
Yes.
From the stand booth.
Okay.
Sorry.
Oh, cannot show. Maybe if you have this camera here from up me to the monitor, can you show the monitor? Can you bring the fluids to that direction? Patrícia, você podia puxar pouquinho isso aí, por favor? Yes. May you have this camera in that monitor over there?
Vai, sobe.
Vai. 14.
Pega a referência.
Okay. He's trying to bring the camera over there. Okay, no.
Right.
That's okay.
20.
That's okay. We use the stent booth just to be so precise with the stent. Can you come back? That's okay. Thank you. Now you went up to 25? 20 atmospheres with the 4.0 balloon.
Yes, distally here, false.
So we have about
25.
75 millimeter coronary stent. We placed the first one with a 35 millimeter long, and the second one was 40 millimeter long. 25. Now we have 75, and Louis is going up to 24, 25. Okay. 25 atmospheres. Can we show the balloon expansion in the next time, please? Rodolfo, I'm just, okay. Now, the blood pressure is fine, the right heart is fine, and now we are 25 again, atmospheres. The balloon is fully expanded. Are you satisfied with this balloon?
Yeah.
The ratio looks good.
So we have here in Dante, we are used to compare the balloon inflation with the reference monitor, just beside us here. So Rodolfo is looking at the balloon expansion and also the artery.
Comparing the size.
Comparing the size. That's a perfect word. Thank you. So we are comparing the size, balloon size, with the artery size.
So we do a ratio 1 to 1.
1 to 1. Because when you are increase this ratio up to 1.1, 1.2,
Cada balão
there is a risk to perforation in a patient like this, 1:1. Now,
4,5, 5.
Rodolfo did the inflation with
The
Louis,
ratio, the proximal range is not 1:1. It's
a little
little
less.
less.
It's 0.9.
Maybe a
0.9, perfect. Yeah.
5,12.
But
We're
we
gonna
can
do
do
a
some angel tests here.
test.
teste.
12.
I think it looks
Okay.
so good.
So good. How about this though?
Yes,
There is some tortuosity,
yeah,
some
perhaps we have a
effect.
from the guide wire here.
Yeah, the distal.
Okay.
Uh,
Some spasm.
okay, the branches are there. So there's you're missing just one small, maybe atrial branch.
Yeah.
Atrial branch.
Yeah.
Can you see that? Atrial branch. And maybe another atrial branch in the proximal part of the artery. Two branches. This one are here in the other.
But do you agree there's some plaque protrusion here also in the proximal?
Okay, so what I suggest to you, still have 5 minutes. Can you do IVOS
Yeah.
now, Rodolfo? Yes. Let's do IVOS.
IVOS.
Just to look at this stent expansion, please. And I'll leave you treating the two distal lesions.
The blood pressure
you
is
wish.
okay. Some nitro.
And now we are going to give some nitro. The blood pressure is fine. And we are going to bring the IVOS catheter to do this and to finish this perfect demonstration what we have done here.
Catheter jab.
Opt cross. 100 micrograms, please.
Now, okay, you have maybe you can have the IVOS in the big screen and the angel in the small screen, please. Just to change.
Right.
Okay. Rodolfo is going to use also the mother and child to get across with the IVOS catheter. Is that correct?
And
Yes.
to
Okay.
nitro.
We are just preparing the IVOS catheter now. Let's see. Now the IVOS catheter.
Yeah.
So you do you think are you okay with this? The IVOS is going to give you additional information to you.
Maybe the proximal edge of the stent.
Okay.
I will check that.
Do you think we need
There is
another
some,
stent?
Malaposition. No,
Maybe you need a
bigger
4.5 balloon.
Yes.
or 5 or
Or 4.5. So if you don't have IVOS at this point, do you think you can live like this, or you would go with a 4.5?
I will go for 5.
4.5. So we are doing IVOS just for a demonstration.
Yeah.
But you would choose a 4. Why don't you do a 4.5 before IVOS? If you were going to do this.
demonstration.
Huh?
Only to.
Well, no,
in my
let's
practice,
do
I
a
go-
4.5.
Yeah.
Let's go for 5.
Balão
Okay.
4,5.
Deu coisa.
4,5, 20.
Pode ser curto. 8, 12, 15.
And while they are preparing, let's do a 4.5. I think we can save time, and also we can demonstrate the power of Angel in your eyes too. Do you agree?
Yeah,
With
totally
Rodolfo,
agree.
would you use a 4.5?
I will do a 4,5 here.
And only the proximal part of the
Yeah.
artery.
Just in the
Is there
edge,
a risk of,
proximal edge of the
is there a
stent.
risk for perforation or something like this?
No, low
Just
pressure.
small balloon,
Yeah,
small pressure.
small
You're not
pressure.
going to 25 yet.
No,
you
no,
see.
no.
What pressure are you going to use?
Only
In the-
to
Okay.
We're using the ratio
the
here.
1-to-1
Okay.
ratio.
And while they are preparing
While preparing the IVOS,
the IVOS, we're going to do a
post
4.5, and we're going to finish with the IVOS.
Yeah.
With the guys that are preparing the IVOS. Okay. Good. I'm enjoying this, watching this case in your work here. It's quite nicely. Now Rodolfo is bringing the 4.5. Can you? Okay. May you have the angel now, the big screen? Okay, good. We are okay. You can keep the IVOS there because we're going to use IVOS later on. This is a 4.5. It's inside of the stent.
Yes. Not
Are you
totally,
sure?
Not
Are you
totally,
sure?
Not totally.
Maybe you need the mother and child
Yes, he's already using it.
to give a better support.
So that shows how complex this lesion here is.
Yes.
Also.
Like,
Although we treated with a stent, it's still tortuosity.
Yes. Let's see.
Huge.
Rodolfo now have a better guide support with the mother and child, the Godzilla.
Yeah.
And now he's bringing the balloon there, bringing back the mother and child, pulling back. Yes.
Pull back
Good.
the balloon.
Good technique. Now you're going to inflate over there or just in the proximal?
Okay.
Inflate, but not very high now.
Yeah.
What the
4,
pressure
5.
is?
I'm using
This is
here
a 4-5 balloon.
8 atmosphere here.
Okay.
Okay.
A little bit
Zero
more.
4-5.
10,
10 up
10.
to 10 here.
11, 13.
Okay.
That's okay. Deflate.
Great technique. We went to up to 11 atmosphere.
11 atmosphere.
11 with a 4-5 balloon. Rodolfo pulling back the balloon. Now he's inflating. Can you see the angel?
Yeah.
What did you do here? You inflate the balloon?
It's difficult to.
Okay, you had some
Trouble to take
trouble
off the.
to take off.
Okay.
Now you're going to bring the balloon.
Here. Oh,
Okay.
just and I think
Okay,
now
looks
it's got a
okay.
little bit better.
Better. How about the proximal part?
The proximal, it's perfect.
Looks okay.
And distal, some nitro, it's okay.
Here,
Distal,
Faust. Here.
Okay.
distal.
The proximal I got.
And
a
the
little
distal
bit
too.
So are you going to inflate the 4-5 proximal?
No.
No? Do you think okay?
I think okay.
Okay.
Ivos.
I was now Rodolfo inflated only falling by angel, and now we are going to check with Ivos to see if your eye is with the angel is okay. Do you think if there is any work to do a little bit more in this artery? Do you think it's fine?
No. It's
Okay.
fine.
In these lesions.
In this
And
lesion.
What are you thinking about the distal lesion? What are you going to do this?
What are
Distal lesions.
we're trying to prepare a stent from the PL and perhaps a balloon.
Do we need to treat those? They are severe enough?
I think perhaps the PL. But now with that we got across the tightest lesion that is the mid portion from the RCA false. I would say we're satisfied with the
Optimal
results
clinical
here.
treatment, it's okay.
Yes.
Okay, yeah.
Maybe.
Okay, that was a great demonstration for lesions in this right coronary artery. Now,
Ok? Põe por segundo aí.
okay, we have 2 minutes
Aumenta a
more.
velocidade.
Only this,
Aumenta a
okay?
velocidade para
And we've been finished
velocidade para
in 2 minutes after this. Can you have the Ivos running the... Okay, great, thank you. Now we are...
Tem que desligar.
we're
Desliga, Wagner. Isso,
inside
vai.
the stand. Are you
Okay.
starting pulling back?
Pull back.
Okay,
Ou um pouquinho dentro do sente.
pulling back?
Ok?
Okay, we are distal now to the lesion, distal part. Distal transition looks good. There is no dissection. This is a large vessel, 1, 2, 3, 4 vessel, 4.5
Well,
vessel.
well,
the stent is well expanded.
Yeah.
It's very
Well
nice.
posted. No
Uh,
bala position.
So there is now we can hit a large amount of calcium from 3 to I would say from 6 to 3. At least at 270 degrees. The stent is well expanded, well opposed. There is no plaque prolapse. It's a great result of Ivos at this point. It's a long run because we have a 75 millimeter coronary stent long. Now the vessel is larger, still with a huge shadow of calcium. Almost 360 degrees. Now is the proximal part. There is some artifact in there, but the stent is well expanded at that point where Rodolfo overexpanded with a 4.5 balloon, as you can see here. Now we are proximal. Again, the stent strut is very thin with the Nobori, but there is no stent malposition in this long stent. Now we are the proximal part of the coronary artery, and now with the aorta.
Very good transition.
It's a very good transition, very good overlapping of the stents. And are you satisfied with the Ivos? Okay, good. And are you going to do a
control
I
angel.
work in the distal lesions, or do not do a control angel just to see if it looks okay? Control
Perhaps
angel.
Control angel.
Control angel.
Yes.
Let's do a control angel, and I'll leave you here to work a little bit more in the distal. If you have time, I'll come back here and we show what you work in the posterior branch, okay?
Okay.
And I'll be work with Ricardo live.
Okay.
Can you see the angel now?
Yeah. You can
Just to see?
Yeah.
A tração tá.
Just a little.
Vamos um testinho?
Okay.
Okay.
Even can you?
Vai. Continua.
Okay.
Ok?
Great. Absolutely great. Absolutely great. What is Mark we have?
Esse é a ultrassound. Aí
Ultrasound.
eu vou-
You are going to bring the IVO scatter. Okay. I'm quite satisfied with that.
Yeah.
Congratulations, guys. Thank you very
Fausto.
much for this nice demonstration. Balloon, guide support, the tortuous
Rotablator.
vessel, calcified, the rotablator, oversized balloon, 4.0, 4.5, and IVOS.
Yeah.
See you later.
you.
Bye-bye.
Bye.
Thank you.